Welcome to this explainer, where we're going to demystify something absolutely wild: hematopoietic stem cell transplantation. We're getting into the full details today, literally all aspects of the process, from how we source the cells to the intense prep work, and a huge part of this journey, the management and complications of acute and chronic graft-versus-host disease. Okay, let's dive right in by framing this ultimate paradox. Stem cell transplants are medical miracles, right? They cure devastating blood cancers. But it's a massive double-edged sword. Think about it. We are literally installing a brand new immune system into a patient. So what happens when that new life-saving immune system wakes up, looks around its new home, and decides that the patient's body is actually a foreign threat? So here's our roadmap. First, understanding stem cell transplants. 2, sourcing and mobilizing cells. 3, conditioning and HLA matching. 4, early complications and risks. 5, acute graft-versus-host disease. And finally, 6, chronic GVHD and its management. Let's get moving. Section 1. Understanding stem cell transplants. Right off the bat, there are basically 2 completely different ways to source our building materials. First up, autologous transplants. This is self-donated. We harvest stem cells from the patient before they get hit with super intense chemotherapy, store them, and then give them back to rescue the patient from the bone marrow damage. On the flip side, we have allogeneic transplants. This is where the cells come from a donor, a matched sibling, a volunteer, maybe cord blood. And this is the big one, because it doesn't just rescue the patient, it entirely replaces their hematopoietic and immune system with someone else's. Moving into Section 2, sourcing and mobilizing cells. Now, to actually get these life-saving cells, you can't just do a regular blood draw. Normal peripheral blood just doesn't have enough stem cells floating around for a transplant. So we use this really fascinating process called apheresis. But here's the catch. Before we can even hook someone up to the apheresis machine, we have to trick the bone marrow into dumping massive numbers of stem cells into the bloodstream. It's literally a step-by-step biological heist. First, we give growth factor injections, like GCSF, for a few days just to multiply the stem cells. Then, we bring in a drug called Plerixafor. This stuff is amazing. It blocks an adhesion molecule called CXCR4. In plain English, it literally unglues the stem cells from the bone marrow. They detach, flood into the bloodstream, and boom, we can catch them via apheresis over the next couple of days. And when you zoom in under a microscope, this is what that harvest looks like. These tiny cells and platelets are literally the seeds of a brand new immune system. We're looking at the true pluripotential stem cells and progenitor cells that are absolutely crucial for getting the new system up and running in the patient. All right, Section 3, conditioning and HLA matching. So we have our materials. The next huge step is conditioning. Think of conditioning as a controlled demolition of the patient's old, diseased system, so we can make room for the new one. Before the new cells go in, the patient gets intense chemotherapy, sometimes even total body irradiation. The goals? Irreversibly destroy the faulty marrow, wipe out any hiding cancer cells, and completely suppress the patient's immune system so it doesn't just immediately reject the donor cells. This demolition can be myeloablative, which is high dose and totally destructive, or reduced intensity if the patient is older or maybe a bit frailer. But for the new system to actually take hold peacefully, we have to talk about the HLA system, or human leukocyte antigens. These antigens live on chromosome 6, and they basically act like ID tags that tell T lymphocytes what's foreign and what's friendly. When we pick an allogeneic donor, matching these class 1 and class 2 antigens is absolutely critical. The bigger the mismatch, the more violently the immune system is going to react. Which brings us to Section 4, early complications and risks. Okay, the old system is demolished, the new cells are in, now we brace for the storm. The timeline after a transplant is incredibly dangerous, and the threats completely shift once you cross the 100-day mark. In those first 100 days, the patient basically has no immune system. The risks are massive bacterial, fungal, and viral infections, especially CMV, which is really nasty and can cause fatal lung inflammation. We also watch out for graft failure and acute graft-versus-host disease. Then, once you get past 100 days, the threats morph into chronic, long-term hurdles. We're talking chronic GVHD, autoimmune disorders, and serious organ damage down the line. Section 5, acute graft-versus-host disease. Let's zoom way in on the scariest early storm, acute GVHD. Remember that paradox we talked about at the start? This is it. It is absolutely wild to think about, but the very cells we infused to save the patient's life are now looking at their new host and going,
hey, you don't belong here. It's driven by donor T lymphocytes actively attacking the recipient. This mostly hits in the first 100 days, and it has three favorite targets. 1, the skin, showing up as a red rash on the palms, soles, and face. 2, the liver, which spikes bilirubin levels. And 3, the gut, causing severe diarrhea and totally wrecking the microbiome.
To fight this, doctors need a scorecard. They use clinical staging, like the Glucksberg score, to quantify exactly how bad the attack is. By measuring the spread of the skin rash, the specific bilirubin levels for the liver, and the sheer volume of fluid lost from the gut, they assign a grade. This isn't just paperwork. That grade is vital for predicting the outcome and deciding exactly how heavy the treatment needs to be. When acute GVHD really flares up, our main weapon to crush that donor T-cell rebellion is heavy-duty immunosuppression. The absolute first-line defense? Massive doses of corticosteroids. We're talking IV, oral, or topical creams for the skin. But if steroids don't do the trick, doctors have to pull out second-line therapies. Drugs like Ruxolitinib, which is a JAK2 inhibitor, have actually been really effective at cooling down that intense inflammatory fire. Section 6. Chronic GVHD and Management.
But what happens if that acute storm doesn't pass and instead settles into a permanent, damaging climate? That's chronic GVHD, and it's a completely different beast. Acute GVHD is a rapid, fiery inflammation, right? But chronic GVHD, which hits after 100 days, is a slow, restrictive, fibrotic scarring process. The body uses myofibroblasts to dump excess collagen everywhere. It looks and acts a lot like an autoimmune disease. Patients can get tight, sclerodermal-like skin, Sicca syndrome where their tears and saliva just dry up, and sometimes really debilitating lung damage. Because chronic GVHD is so widespread and scar-forming, treating it is a massive challenge. Corticosteroids are still the backbone, but patients usually need a whole cocktail of second-line drugs. We're using recently approved stuff like ibrutinib, JAK inhibitors, cyclosporin, and rituximab. And for the really stubborn, resistant cases, there's this incredible, almost sci-fi treatment called extracorporeal photopheresis. They literally take the patient's blood out, blast it with UV light to alter the immune cells, and then put it back in.
Now, after hearing all of this, you're probably thinking, why don't we just strip all the T cells out of the donor graft and avoid GVHD entirely? Well, here is the massive aha moment of this whole explainer. It's called the Graft-versus-Leukemia, or GVL, effect. The exact same donor T cells that cause Graft-versus-Host Disease, they are also actively hunting down and destroying any leftover leukemia cells hiding in the patient's body. It is the ultimate double-edged sword. The clinical data is crystal clear. Patients who get a little bit of GVHD actually have lower rates of their cancer coming back. Mild GVHD is literally clinical proof that your new immune system is switched on, highly competent, and actively patrolling your body to kill the cancer that started this whole nightmare. It's so effective that doctors will sometimes deliberately inject donor lymphocytes into a relapsing patient just to trigger this specific anti-cancer attack. It's a razor-thin tightrope. You're balancing curing a deadly cancer against causing a brand new, devastating disease. So I'll leave you with this final thought to chew on. As our targeted therapies and immunosuppressant drugs get better and better, will medical science ever be able to perfectly balance the life-saving graft-versus-leukemia effect while completely turning off the destructive forces of GVHD? That is the holy grail of transplant medicine right now, and researchers are inching closer every single day. Thanks for joining me on this deep dive. Keep asking questions and keep exploring.